Okay, so some common urinary problems. Incontinence is one of the most common urinary problems we will see. There are different types, and the different types actually have different causes and different management. Urge incontinence is when someone has a frequent, strong urge with leakage. They may also have incomplete evacuation of the bladder. It's caused by bladder contractions. Management is decreasing bladder irritation. That's the first thing. We want to decrease bladder irritation. We may do bladder training, and then there are anticholinergic medications that can help. So we can decrease bladder irritation by encouraging hydration and discouraging caffeine and alcohol. Both of those irritate the bladder and cause more frequency. Bladder training is increasing the capacity of the bladder. Sometimes patients who have urge incontinence have spent so much time afraid of an accident that they go to the bathroom very, very frequently, and their bladder capacity has shrunk. So if they increase their bladder capacity, they may actually decrease the amount of spasms they're having, or bladder contractions they're having. So that's done with timed voiding, and we want to have them gradually increase the time intervals to increase their bladder capacity. So if they've been going to the bathroom, say every hour, we want, or maybe every 30 minutes, we want to have them wait an hour each time, and they set a timer and they don't allow themselves to go until that hour. And then once they can do that comfortably, then they stretch it to an hour and a half. Now, obviously that's going to need to be done at home. And or using protective undergarments, because they may have some accidents in the process. We also want to teach them some pelvic floor exercises to strengthen the pelvic floor. There are some things that can be used to suppress the urge to urinate. So when they have that urge and they want to run to the bathroom and their timer hasn't gone off yet, we want to teach them to do some deep breathing, try to relax without relaxing that sphincter, and often that urge will decrease after a few seconds to a minute. If those things don't work, then the patient may be put on an anticholinergic medication, which relaxes the bladder and makes them have to urinate less frequently. Now, anticholinergic medications are going to cause urinary retention, so that's something we need to be aware of. Stress incontinence is the loss of small amounts of urine with increased abdominal pressure, and it is caused by weak pelvic floor muscles, and it's managed by bladder training and Kegel exercises. Sometimes, especially older patients, will use support devices like a pessary. There are some surgical procedures that may be used for stress incontinence. They have mixed results. So some patients will try that. Some patients will not want to go that route. Overflow incontinence is caused by urinary retention. The bladder gets so full that it literally can't hold anymore, but there's something preventing that bladder stretch receptor from triggering. And so instead of a bladder contraction and emptying the bladder gets full and then it just leaks. Small amounts of urine leak, unless it's a complete obstruction. Now, if someone has urinary retention and the obstruction's complete, they won't leak urine and they'll keep making urine. It can actually cause the bladder to rupture. So, but overflow incontinence is from urinary retention. So management is to manage the retention. If it's permanent, if their bladder is never going to be able to contract again, then they may either have an indwelling catheter or they may use intermittent catheterization. For infection purposes, to prevent UTI, intermittent catheterization is actually a safer alternative rather than an indwelling catheter. Reflex incontinence is sometimes seen with a neurologic injury or spinal cord injury. The bladder reflexively empties, usually without warning. This is not the same as overflow incontinence. This patient, their bladder just by reflex decides to contract and empty, usually completely. This can be managed by emptying the bladder on a schedule. There's a maneuver called the Crede maneuver that can be used with a bladder that doesn't want to contract when it's supposed to. But this also can be managed by intermittent catheterization. Total incontinence is unpredictable and involuntary. It may just be unpredictable episodes of wetting, or it may be continuous drainage. Total incontinence doesn't respond to treatment because there's either no communication, or the urinary sphincter is not able to hold the urine. Management is protective undergarments. Men can use a condom catheter. If you're placing a condom catheter, remember never to tape it completely around the penis, because if they get an erection, that can cause constriction. And condom catheters are associated with skin breakdown. So make sure that you're doing good skin care. Someone with total incontinence may also have an artificial sphincter surgically inserted, in which case, in order to activate that, they push a button and that relaxes their surgical sphincter and allows them to void. Functional incontinence is when someone physically is able to be continent, but there are factors that interfere with their ability to get to the bathroom. And that can be mobility issues. Maybe they are able to recognize the urge and hold their urine, but they can't get to the bathroom without assistance to transfer. That would be functional incontinence. Cognitive, maybe they can't recognize that they need to urinate, but if someone takes them to the bathroom, they can go appropriately. Or environmental, and that can be just because maybe there's not an appropriate place available. Functional incontinence is best managed by toileting schedule, taking patients to the bathroom consistently on a toilet or on a schedule, sorry, and removing barriers to toileting. Incontinence is often multifactorial, and a lot of patients have more than one type of incontinence, so it may take some time to assess and treat. Patients who are struggling with incontinence can keep a diary and begin with some general bladder health measures to try to figure out how that, what's causing it and what the best measures are to treat it. It's really best to be honest with patients about the time that it can take to evaluate this and treat, because if they're expecting to go to the doctor once, fix the problem and be done, they may get frustrated with multiple return visits and not much results or incomplete results. Urge and stress incontinence are often related to pelvic floor weakness. So if other interventions are unsuccessful, then they may have surgical repair. There also have been some, there's a treatment where they inject collagen around the urethra to strengthen the sphincter. Not sure about research on that, just know that it's done. Okay, we're going to come back in the next section and talk about urinary retention.